Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode. All right, welcome everyone to another episode of Decoding DX. We have an awesome case tonight that Ben will present to us, and we have some amazing discussants. So we'll go ahead and start out. Lindsay, if you want to introduce yourself, tell us who you are, where you're at, and something about you that does not involve medicine.
Yes, I'm Lindsay May. I am a third-year medical student in Kansas City with KU Med, and I was able to achieve a lifelong dream of seeing aspen leaves in the fall this year. So
I love it. That's awesome. And
Where did you go to see them?
we were in way western Colorado, Durango, Silverton.
Lovely place.
And then we have Dr. Miller, who has requested we call her Nikki from now on. Go ahead and introduce yourself, Nikki.
Hello, everyone. I'm Nikki Miller. I'm a third-year internal medicine resident at KU. I did all my schooling through KU, so I love being at KU Rack Chalk. Something about myself that is not have to do with medicine. My husband and I love to travel. We haven't gotten to do too much during COVID, but look forward to traveling again once it's a little bit safer out. So,
Well, we're going to go ahead and get started. Kind of going to go through some basic like chief complaint differential stuff here to start and get some proper representations, just because of the breadth of complaints that could cause what our case is tonight. And so our chief complaint, straight out of the mouths of our wonderful patient, is, I turned up my oxygen. And so, Lindsay, I would love to hear your starting points for categories of a differential that could encompass a new oxygen requirement.
So my brain first jumps to acute exacerbation of COPD, just with how common that can be. Other things would just be more cystic fibrosis, more chronic diseases, specifically pulmonary in nature, and then heart as well. So mostly pulmonary and cardiac and systemic. So for cardiac, a couple of things would be like heart failure with some complications there. Definitely would need to change treatments. And then for systemic, something like sarcoidosis or, lupus can do anything. And just having really targeting the lungs in that sense. That's kind of my first thoughts.
Yeah, those are great first thoughts, especially since one thing that we can assume when somebody, quote unquote, turns up their oxygen is that they have oxygen to turn up, which generally implies that there's something going on with the lungs. Anything you'd add, Dr. Miller, before we add some of the HPI?
think about those big things that not necessarily are from somebody that's on chronic oxygen, but not on oxygen at all. So that would be a totally different category. But thinking about those things that are going to kill your patient, like PEs that are going to cause hypoxia as well, or needing somebody to start on oxygen or turn up their oxygen. So some of those other big key things just be thinking about as well. But we'll see what the case brings. But it sounds like very much that this patient has oxygen requirement and needs to turn it up. So
yeah, perfect. So we have a 89-year-old male who has a history of cryptogenic organizing pneumonia, coronary artery disease, status post cabbage in 2019, mild cognitive impairment, and a history of esophageal cancer, who comes in today with a new 4-liter nasal cannula oxygen requirement. So all getting started here. First off question, I'll send it over to you, Nikki. What is cryptogenic organizing pneumonia, henceforth known as COP, on this topic? And what is that disease, and what does it mean, and what is some of the characteristics of it?
So it's more of like inflammation in the lungs, right? Scarring, obstruction those airways, right? The way that I think about it is like a interstitial pneumonia of some sort, with lung inflammation and scarring that can obstruct the airways that can cause you to have hypoxia. So.
Yeah, and I would only add to that. So the cryptogenic is kind of a grab bag term, almost like idiopathic, meaning hidden. But unlike idiopathic, it doesn't necessarily mean unknown. And so one of the categories of organizing pneumonias is that there are multiple different predisposing causes to them. And yet often in clinical pictures, it just gets labeled as cryptogenic organizing pneumonia, when in fact it might be drug-induced, radiation-induced, infection-induced, or sometimes even HIV or viral parasitic origins have also been identified. In the drug-induced, there's mostly chemotherapeutic agents, though there is a huge list of medications that can cause that. So a little bit more details for his cryptogenic pneumonia. So he had esophageal carcinoma, received chemotherapy and radiation, and then he had subsequent COP development following, requiring 4 to 6 liters of nasal cannula O2 back a couple years ago. And so over time, with treatment, he improved to 2 liters of nasal cannula oxygen. It was stabilized over 9 months. Initially being treated with prednisone 80 milligrams, which is the mainstay of treatment to do steroids. And then he was tapered to 40 milligrams for 4 months. And then down to 20 milligrams and then to 10 milligrams over a 2-month period. And then eventually off. And that finished up right about a month ago. So then for 2 weeks after finishing the taper, he felt fine at home on the 2 liters of nasal cannula. And then he developed cough, malaise, periodic lightheadedness. And then 2 weeks ago, last week ago, he started using his wheelchair 100% of the day, and then increased up to 4 liters of nasal cannula at home. He hasn't had any hemoptysis, no sputum production, no chest pain, and no GI distress, like nausea, vomiting, abdominal pain, etc. So just to restate the timeline for you, 9 months of steroid treatment, off for the last month. 2 weeks of that he was fine. 2 weeks ago he started getting a little bit worse, and then a week ago was when he really started feeling more symptoms than what he had previously. And so with this, let's just kind of go ahead and update the problem representation. So Lindsay, if you could give a stab at what just kind of a summary of what problem we're looking at and what the situation is that's going on.
So with this 89-year-old male, has a significant history for esophageal cancer treated with radiation and chemotherapy with cryptogenic organizing pneumonia, which was previously controlled with steroid therapy, which he was appropriately tapered off a month ago, and then all the symptoms kind of you described. For how this kind of, do you want to know differential then?
Yeah, that's actually the next question. Go for it.
So for differential, this definitely changes it a little bit. Since I'm on endocrine, I have to say adrenal insufficiency with his fatigue and some of his symptoms, but then of course a fear of metastatic cancer from his esophageal disease, and then just re-inflammation of that lung disease coming back, especially since he's off the steroid therapy.
Perfect. Any can't miss diagnoses for him?
Kind of like Nikki mentioned, the kind of acute could kill you that maybe would be easy to miss if you're expecting a chronic disease like still a PE or something like that. We haven't seen the vitals or anything, but it would be more of a chronic onset of that, which would be weird.
Nikki, how would you modify the problem representation or update the differential? And then what would be some of your can't miss diagnoses?
Yeah, so I think definitely looking the can't misses are your PEs, your MIs, things like that, but most likely not in this case. Really liked how you brought into the endocrine side of things, since you've been on endocrine with the adrenal insufficiency. As you notice, he was on a lot of steroids at one point. Infection, things like that are can't misses in these, especially with his symptoms. And then something else that you can always think about with patients, not so much in his case, but in patients is like neurologic status and neurosymptoms or neurogenic processes that can cause a new oxygen requirement, although I don't think it's going to be in this case. So yeah.
Yeah, that's great. And then since we're here and he's shown up in our emergency department, you're walking out of the room, you have a little bit of the story, you've just heard this. Anything, we'll throw this one to you, Lindsay. Anything that you said, this is what I want to do for him first?
I think treatment or diagnostic or both, I guess.
Go ahead and do treatment. We'll save the diagnostic for after we do the physical exam.
Oh, you mean for physical exam? What do I want to do?
No. Initial management that you would be thinking about for this person before we did the physical exam. Then we'll do the diagnostic stuff before. After that.
I would make sure he has oxygen and consistent monitoring of that, keeping it at an appropriate level.
What's appropriate level? What would you be targeting?
With his history of COPD, it would be 88 to 92 or low 90s. But since he's kind of different, I don't know if that's different.
Yeah, and just to clarify, COP, not COPD.
Okay. Did he have? I thought I had. Okay, never mind.
Yeah. No, it's totally fine. 88 to 92 is absolutely the number there. So, Nick, anything you'd be thinking about urgently or emergently for him?
Well, something else that I was thinking about. So you guys talked about he was on chemo and radiation. I forgot when was he on these last?
So these treatments all stopped before all concluded before the COP initiated, which is right around a year ago.
Yeah, so you always have to be thinking about these things with probably more acute cases, but chemo and radiation, the radiation-induced fibrosis and stuff like that. But what was your other question? Sorry.
Any treatment that urgently, emergently you'd be considering for this patient if they're in the ED for you?
Really getting a good sense of where his oxygenation level is at. So he's on supplemental oxygen. Your target, would be 88 to 92% or higher than that. And then obviously getting an ABG and seeing if he is oxygenating well.
Yeah. Perfect. So we'll add some of the history and then we'll get down to the physical exam. So in the past medical history we already talked about. Only thing to add would be that he has a history of hypertension, the mild cognitive impairment that we talked about, and then also the hearing impairment. Medications, he's on everything you'd expect for someone with hypertension, lisinopril and hydrochlorothiazide, doesn't have any allergies, and then it's just on a baby aspirin and then some medications for GERD. And as far as social history, health behaviors, and family history, the social history, previous school teacher and pastor, prior to his recent medical illness, he lived at home with his wife, and he's been in assisted living recently since he developed the COP and the oxygen requirement. And his family spread all throughout the country. And then he is a non-smoker and has 3 drinks of alcohol a week. And then the family history is non-contributory for this case. So with the mild cognitive impairment and hearing impairment, how does that change how you go in and conduct a physical exam and gather history from this patient? Lindsay, I'll have you start.
I think it would be important to include his family and include contact with that assisted living that he was at, depending on his status, at first introduction, but making sure you're getting word from people who were caring for him most closely, and then speaking loudly and writing things out, writing them and showing him if he's really impaired, and ensuring that you take the time to talk.
And then when you go in for your physical exam, what kind of things are you looking for?
How he's breathing, any retractions, use of accessory muscles. If he looks blue, you'd have to maybe pull his mask down and look at his fingertips, and then looking for signs of chronicity, of maybe he's been under oxygenating for a long time. So looking at his fingernails, and then also like any signs of infection, if he looks sick versus just presenting with an increased oxygen need.
Yeah, that's a great point there of how do you tell if someone is sick or not sick and what the disposition is going to be. Nikki, when you're walking in on this physical exam, what are some of the like maybe 3 or 4 things that you're looking at to say, is this patient sick or not?
Yeah, so something that you definitely want to be concerned about in a patient that's coming in with hypoxia is, how do they look? Do they look really restless? Because patients that are hungry for air are going to look more restless. Are they somnolent? That's another big one with patients that come in with or rapid responses in the hospital. Do they have altered mental status in these patients that are coming in with increased oxygen requirement, or you're noticing that right off the bat? How are they breathing? Are they using accessory muscles? What else? And then I very much agree, looking at the physical exam, looking at their lips, looking at their, extremities, but really focusing on how they generally overall appear, and then focusing on those things that you worry about with hypoxia. And then, another thing along with mental status comes agitation sometimes with air hunger, if they really are hypoxic or not.
Cool, thank you. So we got the physical exam, and so I'm just going to list off the pertinents, either positives or negatives, and not all the rest of the fluff that may enter into the medical chart at times. So as far as vitals go, blood pressure 98/52, heart rate 84, O2 sat 93% with a respiratory rate of 18, and that's on the increased 4 liters of nasal cannula. And then his temperature 37.9 degrees Celsius, so afebrile. He is tired looking. He doesn't have any mucosal power. His lips, since we've asked about those, have a normal tone, nice and pink. And mucous membranes still appear to be moist. His regular rate and rhythm, soft peripheral pulses, crackles bilaterally that are worse than the bases, and then he's on the 4 liters of nasal cannula, but you can't appreciate any use of accessory muscles. And then as far as the extremities go, they are cool to the touch, and then they did have kind of those soft pulses that we talked about previously. So Lindsay, anything you would add or change to your problem representation or differential?
Can't think of anything to add that we haven't discussed already. But I think the pulmonary is kind of higher on my differential than like a cardiac presentation, I guess. And systemic would be lower, the sarcoidosis lupus.
Yeah. Which that's a good distinction to make, to start thinking about what are we looking for specifically. I know you're on endocrinology. What is making adrenal insufficiency such a highlight for you right now?
For me, it's his hypotension, which, okay, yes, I would add to the differential just like medication, since he's on a couple hypertensive meds. And then the withdrawal from chronic steroid use, and then sort of his presentation of being like cool to the touch, and that he's not using accessory muscles, he's not really straining for breath, kind of pulls me more that direction.
Mhm.
But again, I've been on.
a little recency bias. So, Nikki, anything you'd add for differential with this physical exam?
He's had no exposures recently or anything. Like no
You bring up a great
hypersensitivity, pneumonitis.
point.
Sure. So I guess you could add that to the differential, because I know that presents decently similar to cryptogenic organizing pneumonia. You also have to think about shock in these patients. So sepsis, either like infectious, so like a septic shock picture, and then like cool to touch. You always have to think about cardiogenic shock. And although it seems like, I mean, he does have a cardiac history, so be thinking about that as well. So those really serious things.
Yep. Yeah, and a couple of details. I think we missed this earlier. One exposure that he might have could be the assisted living facility that he moved into about 9 months ago. And then also this case is one of the few that put together that's time dated, in that it took place in April of 2020.
Okay, so then, Lindsay, do you want to?
COVID.
Yeah. Do the honors, and that'll actually come in a little bit later. This patient, we can get a COVID test on him, and it's negative, but that will have a part to play in the eventual portion of the case. So let's do lab test. It's April 2020. Patient comes in the hospital. Lindsay, what are you ordering for him?
COVID test.
Great,
ABG
done.
that we discussed. CBC and CMP with his. I want to see kind of the chronicity of his hypoxia, which the CBC could help with, and then also kind of his perfusion status, since his blood pressure is so low, and seeing how end organs are responding to that. And then I think the ABG will tell us a lot that we'd want to know. I'm sure there's others. Cortisol and ACTH. Sorry.
Nick, anything you'd add?
Not necessarily right off the bat. I think we could start with those, and you already said COVID was negative, right? So, and then we haven't discussed imaging yet. So I think those would be a good start, and then we can kind of tailor from there.
Yeah, absolutely. So ABG
and maybe
did not
hold
happen.
off on the cortisol for a second.
We'll hold off on the cortisol. The ABG was attempted and failed, and so it did not get in with the initial labs because they just couldn't get the stick to go right. But as far as CBC goes, an elevated white count of 14.2, and then 13.6 for the hemoglobin. The CMP had a sodium of 131, and then everything else was within normal limits for his CMP, creatinine of 1.02, and then HCO3 of 22 for the bicarb. ABG was not obtained, and then they went ahead and did the COVID testing, and then because of erroneous lab orders, he also got an RVP, which was negative, and sputum cultures, which are pending just because of the SATs there. So at this point, labs, imaging you'd want to order? Anything else as far as an imaging side or the lab side?
So I will add a quick little pearl on RVPs. I don't know if you guys know, RVPs are very, very expensive lab tests, and there's this highlight that comes up. So it's not something that we always start out with, but if we're really, interested in this patient, if he has some exposures and we want to rule out some things, then it's a good test, but it's something that you don't always start out with in these patients. And then of course, sputum cultures are great. Just be careful because they will take some time. And then there's also some other different pneumonia tests that you can use that are a little bit quicker to really rule out those major ones to help guide your treatment. So that would include like your Legionella and your strep urine antigens for some pneumonias. And then one of the big ones that there's a paper on right now is the MRSA pneumonia screen that can really tell us if we should be including vancomycin or not in our patients that, like him, would possibly be started on antibiotics, and how can we tailor those as quickly as possible. So just keeping that in mind when you go through your initial labs, because I saw the RVP, so I would have probably added a few other things as well.
Yeah. And Nikki, how long does someone have to have had Legionella or strep pneumo before their urine antigen pops positive? Do you know?
I don't know. I'd have to look it up.
That's
Yeah,
okay.
but that's
I don't either. I've never had that question before, actually.
Yeah.
Any imaging that you'd want to get?
I think he's in the ED, so he'd get a chest x-ray, and I don't know how useful it would be. But he probably has recent imaging with his treatment therapy, so comparatively it could be helpful.
Yeah. Brandon, you want to pull up the x-ray? So it's a pretty grody x-ray. How would you start to think about that, Lindsay?
The trachea is midline. I don't appreciate any bone fractures. The cardiac size seems appropriate. I do appreciate some hyper opacities in the middle of the airway. And then I can visualize the diaphragmatic edges, but it also looks like there's hyper opacities specifically on the right. So,
That's awesome. Well done. It seems you had a system for that. What was your system?
A, B, C, D, E.
And what does it stand for?
Airway, bones, cardiac, diaphragm, and everything else.
Awesome. Thank you. That's very good. And so then this was followed up with a CT scan.
Real quick. In these patients, I know they'll come straight through the ED and they'll get a chest x-ray that's portable. So they'll immediately just get the portable chest x-ray. But a good point is if patients can, a 2-view chest x-ray will tell you quite a bit more than just that 1-view chest x-ray.
Is it 1 view is no views? Is that the phrase? Yeah. So here we see the CT scan. It's really showing the same disease pattern. And we're seeing on the x-ray, we saw bilateral, peripheral, patchy opacities. On CT, we're seeing these subpleural opacifications, and then intermittent bronchial wall thickening. And also, if you can appreciate the air bronchograms as well. And all of these findings, air bronchograms are on the left, our right, patient left. Thank you, Brianna. That's very well highlighted. Brianna has an excellent 10 cm on CT findings that taught me much about this that you can find on our YouTube channel. So these findings are all consistent with cryptogenic organizing pneumonia. And so we had that initial diagnosis of the relapse. However, just kind of to move the case a little bit along for management, the thought was also along the same suspicions that Lindsay has had, and that something is going on with all of these steroids and with some of these physical exam findings, and then also with some of the hyponatremia that was there, enough to convince them to go ahead and draw a random cortisol. And the random cortisol came back at 2.8, and we see the cries of excitement. And so another piece of the history that kind of cued this in was that he'd had some recent dizziness when standing and had started using his wheelchair at home all the time. And that was because he was scared of falling. And so our lovely gentleman had been self-treating some orthostatic hypotension just by sitting all the time. So all of that was kind of tied together, and they said, I wonder, and they tossed a random cortisol on. It was 2.8, and then they actually did not decide to do any follow-up testing.
When did they order the random cortisol?
It was the inpatient team. It was not ordered in the ED.
Yeah, yeah. And then something else good to do is always compare your chest x-rays to the ones previous, right? So just remembering that as well. Anytime you have an EKG, anytime you have a chest x-ray, always comparing those to the previous ones. But yeah.
Yeah. Very nice. And so I was on this case, and as a third-year medical student, was very baffled and pushed to order a cosentropin stimulation test, because I read in the textbook that's what should happen. And my attending very forcibly told me no. And said, we're not ordering it. It's not worth it. And so I would love to hear some of your thoughts, Lindsay, especially being on endocrinology, and then Nikki as well, as to why in this case we don't actually need that cosentropin test. And where do we go from here?
Yeah, I think I totally understand your mentality during the case, because that's like what I've been reading on up to date all week. But then with him, we have an explanation for his adrenal insufficiency. It's quite linked to his history of use, his recent discontinuation. And so it's likely not necessary to have further testing inpatient, would be my thought process.
Nikki, would you add to that?
Did he get put on any steroids when he was placed in the hospital?
He did.
He did. Okay. So
once they saw the random cortisol, they started the steroids.
yeah.
How does that affect your cosentropin test?
So it'll skew it, so then you won't be able to interpret it. So
yeah. And this also highlights another.
Was that why that they didn't order it?
That was, and then also I had asked initially why, if he wasn't in shock, they didn't confirm the diagnosis prior to starting the steroid replacement. And the answer essentially was, with a serum cortisol that low, our suspicion is so high, we don't need to delay. Because then they would have had to delay probably 24 hours total to wait on the lab and the administration and everything to get the secondary testing, which really highlights another one of the kind of teaching points of this, which you've talked about a little bit with the RVPs, is that sometimes our desire for diagnostic precision via laboratory imaging or specialized testing actually only adds to cost and makes us feel good, and we're treating our own curiosity rather than actually improving necessarily the patient outcomes, which could fall under things we do for no reason, could fall under unnecessary testing, could fall under excessive academic practice of medicine, where we're doing curious tests rather than necessary tests. But it is something that matters to the patients and to the health system as a whole. And so the cosentropin was not ordered, to my chagrin. So we'll do a little bit of the treatment course, and as that unfolds, we'll kind of have a little bit more discussion about this patient's case, and then also about what ended up happening with it to kind of close out our time tonight. So this patient was admitted to medicine. They were started on prednisone 80, which was pretty high dose, and then that was kind of dropped down to prednisone 40 per day. All the cultures came back negative. They ended up getting a urine antigen that came back negative. But the patient continued to have some orthostasis in the hospital, and initially had an improvement in their O2 down to 2 liters nasal cannula, and then worsened to 4 liters and 6 liters over the 6-week course, or sorry, over the 2-week course of their admission stay. And so in their admission, we really had 3 primary problems that we were addressing. One was the cryptogenic organizing pneumonia that was relapsing. One was the adrenal insufficiency, and then the other was the orthostasis, which we presumed was primarily due to the insufficiency, but clearly as evidenced by failure of response to steroid administration, was not entirely due to insufficiency. So we'll kind of start there in terms of like, Lindsay, how do you think through causes of orthostasis?
Yeah, so I guess I just think about the patient, and like one thing that you're always going to think about with someone with hypertension is his medications, and so adjusting doses with that, and that aging can be a factor in it too. And then also, I think just when we put our patients in the hospital, they don't get around much and they don't move very often, and I think that can worsen their orthostatic hypotension as well. And then something that I'm not sure would be in this patient would just be like the autonomic dysfunction. I don't know if COP can trickle into that and affect that. I'm not sure much about that disease, but then also just if this were a patient that had a long history of diabetes, or if this was a patient who was struggling with other kind of neuro targeted diseases at some point, that's something we could consider. Yeah, and if he's drinking enough water, I don't know.
Those are some great thoughts. Nikki, how do you think through orthostasis?
Yeah, so you have to think about like cardiogenic causes, neurologic causes of your orthostasis. And then you also have to be thinking, through those things with like vertigo, central versus peripheral. Was he having any symptoms like that? And then, through your cardiogenics, going down both of those routes to really differentiate the two. So with the autonomic dysfunction, absolutely. Especially with patients with diabetes, but he did not have diabetes, did he? No. And then and then he does have this cardiac history, looking into that a little bit further, and looking through his medications as well. I fully agree.
Yeah. So to classify someone as having orthostatic hypotension in the hospital, how do you do that? Either one of you can jump on that.
I don't know if it's different in the hospital, but I know diagnostically it's a drop in systolic over 20 or diastolic of 10, 5 minutes after standing from either sitting or supine, I believe. So you just do that.
Yep. Who does it? Do you do it? Does the nurse do it?
I think the nurse probably ends up doing it, but you should do it.
We can do it. Yeah. Anybody you consult for management of orthostatics, evaluating?
I'd think cardio with his history.
Nikki, who would you want to consult for the submission?
I think you'd have to do further evaluation before you put in any consults quite yet, obviously. Because you can do a little bit further workup, adjusting the medications. But yeah, you could consult cardiology.
Yeah. One thing that we did for some of the orthostatic concern and kind of disposition was consulting PT, OT, and speech.
Oh yeah, always them.
Yeah, they're like the default consult.
Yeah.
And the OT was actually the group who was doing the orthostatic vitals for us, because they would run him through and then they would walk and see how I was able to tolerate walking, and PT kind of signed off and OT kept on because we had that initial goal of getting him back to the assisted living where he'd been previously. And so, Nikki, I'd love to hear you speak just a little bit about the roles that PT, OT, and speech play in determining patient disposition during an admission and then kind of when you're preparing for discharge. Yeah,
so they're wonderful services that we get on board with, most patients that we feel that they have the need for those for any of those certain things. So with physical therapy, especially in this patient who's been having dizziness and lightheadedness, so they're going to start to help evaluate, their disposition, obviously. They're going to work with the patient, and they're going to work with the patient, especially with orthostatic patients. You bring up a good point that I don't always think of them as a consult service, but they absolutely are. So they're going to teach that patient with orthostatic vitals, to get up slowly. That's one of the easy treatments with orthostatic hypotension, is teaching somebody how to get up slowly and what kind of what kind of tools that they can use. Can they use a walker? How long should they sit on the side of the bed, and giving them those different tools to use in order to limit the orthostatic hypotension, and same with OT as well. OT, another point with orthostatic hypotension, is one thing that we do that's really easy, that's non-medication related, is giving them compression stockings. So they're going to help teach those patients to put on those compression stockings and how to use those compression stockings. And then they're going to really help with the disposition of this patient. Now, he came from an assisted living facility. Was it assisted living? I can't remember.
Assisted living.
Assisted living. Yeah. So he might require, rehab for a certain amount of time. Patients become very deconditioned in the hospital. So we have to be aware that while they're in the hospital, that physical therapy and occupational therapy are really good resources that we can use to make sure that these patients aren't being deconditioned while they're in the hospital. And so working with them for a safe dispo, as well as working with our social workers, which are wonderful resources while we're in the hospital, working with our social workers on what best insurance needs they have, and how their insurance will fit into where their disposition is. So it's we all kind of work together on where to go from there. And then speech, speech in this patient, did he have any speech needs per se?
He did not. He had the mild cognitive impairment.
Yeah.
And the hearing impairment, but no actual speech or swallowing needs.
So actually, speech really helps with cognitive impairment as well. So speech has quite a few different abilities to do while they're in the hospital. So they can come help evaluate that as well. But speech is, obviously really needed in patients that come in with dysphagia, or, he was having a cough and things like that. So was he aspirating in any sort of way, to come evaluate if he's aspirating? He is an older gentleman that could be contributing to a worsening pneumonia, or pneumonia on top of his like an acute infection. So speech could help you in this patient in that way as well. So.
Yeah, that's great. Can you explain one phrase that you mentioned for me that we hear tossed around all the time, but rarely clarified? You said you want to help him have a safe dispo. What constitutes safe, and what factors are you thinking about whenever you're clarifying for that?
Yeah, so when I think about a safe discharge, it includes quite a few things. So it also includes what the patient thinks is safe as well as what you deem as safe. So obviously making sure that this patient's oxygen requirement is near his baseline, or he's trending in the right direction. So one safe dispo from my point would be, is the patient getting better? And is he medically safe? So that's the one thing that we can use our medical knowledge to determine if they are safe to discharge. And, are we on the right therapies, things like that, to make sure that he has a safe discharge. And then a safe discharge also means, is the patient going to a safe place home? Is it home? Is it an assisted living facility? Is it rehab? Is it where they're going to be able to get a skilled nursing facility? So there's so many different options from that standpoint of what safe means there. And that's just based on the needs of PTOT and what they deem as necessary based on their expert advice of what is safe for them to go home. And then do they have the resources to go home? So a lot of patients that come into KU don't always have, the perfect resources that can go home with, but what can we do to make sure that they do have those resources? Can we provide them with the walker? Can we provide them with the compression stockings, like in this case? And then the medications, how can we supplement those? A lot of patients have difficult times getting certain medications when they leave the hospital. And there's certain voucher systems and making sure that we can provide them with the cheapest cost and options when they go home as well. So working, it's very much an interprofessional, a safe discharge is very much interprofessional, working with the pharmacists, working with the social workers, the physical therapists, the occupational therapists. And then of course, last but not least, making sure that their families understand what happened during the hospitalization, especially during COVID. It's been a difficult time not being able to have all the family members present in the hospital to understand everything perfectly. So, making sure that their family's on board with what happened during the hospitalization and they're educated and what best suits the family in going home. But also making sure that you don't keep them in the hospital longer than they need to, but also preventing them from coming back as soon as, the return rate that all hospitals look at. So.
Yeah, thank you for that. We're going to push pause on where that conversation is headed, because we're going to come back to the disposition to wrap up the case. I wanted to circle back and talk just a little bit more about the adrenal insufficiency and rehash some of the COP that caused him to come in. So I'll just kind of give a little bit of info on COP relapses. And then I'm going to have Lindsay, with your recent endocrinology rotation, fill us in some on some adrenal insufficiency stuff. So COP relapses are actually fairly common, and it's a disease that shows really good response to steroids, but then also can relapse and then often will subside again with steroids. And in this patient, we actually ended up seeing some resistance to steroids in their treatment, and we never really identified what was going on with that. But risks of relapse are whenever you have bilateral lesions for the COP, which this patient had, traction bronchiectasis, which we don't know if he had the first time, and then a lack of full remission, which we're presuming that he had, given that he never got off of the oxygen requirement that he's on. And then also it's most common to occur when the steroid dosing gets below 20 milligrams a day, and he had to come off as well. So of those primary relapse factors, he had 3 of the 4. And then he may have had the 4th as well. We're unsure based on some unknown history. And so that's what caused him to come into the hospital. The steroid dosing is also probably what caused him to have adrenal insufficiency. And so, Lindsay, can you just kind of clarify the difference between a primary, a secondary, and a tertiary adrenal insufficiency?
I'm so glad I looked this up today, not related to this, but primary would be something specifically attacking the adrenal glands. So an example would be tuberculosis or like Addison's disease, an autoimmune attack at the adrenal glands. Secondary, by my understanding, secondary is really an issue with the pituitary itself. So like total hypopituitarism or more rare occurrences there. And then tertiary is what I believe this patient would have of an outside source of the steroids, then suppressing the ACTH and causing a lack of stimulus from the brain to the adrenals. And so the adrenals shrivel up. And then when the stimulus is taken away, they aren't able to make it by themselves anymore.
What a great, concise definition there. And then what about for diagnosis and some of the tests that you could do? Not all the details of them, just what some of them are.
So from what I've learned this week, the timing is very important. So if you're unsure, always ask an endocrinologist. But the cortisol level would be the #1 most important. If that's indeterminate in a certain range, you're going to want to do a cosentropin, a fake ACTH stimulus. And then once that level is known to you, you kind of want to start looking at what could be causing it. And so that's when you're going to want to know the ACTH, the stimulus level, and whether that's low or high will let you know if your problems are coming from the brain or from the adrenals.
Awesome. And Nikki, any pearls to add for AI classification, diagnostic tips?
Well, I was going to add a little bit more on the COP. So I haven't seen too many cases of this, but when I did see it, I was on Pulm Consults, and one of the big things with COP to really highlight is that it's often misdiagnosed when it first comes in. It's often misdiagnosed as just your CAP or your community acquired pneumonia. So often these patients are initially treated with antibiotics, and then they don't get better. And that's when they start to say, well, when patients don't get better on these antibiotics, then, where do we go from here? And, what kind of exposures have they had that put them at risk, like the radiation or anything like that, that put them at risk of the COP. So just really understanding that it's often misdiagnosed and antibiotics are started. Now, this patient had COP and came in with, worsening symptoms after a steroid taper. So it was more of a classic relapse per se, although we went through quite a few different differentials, which was fantastic. But just knowing that often when these patients first come in and aren't diagnosed with COP first, is that it's often misdiagnosed or diagnosed initially with CAP, and then they fail antibiotic therapy. And then that kind of brings in the MRSA NAIRS screen. So just make sure that you're getting those. And then something else that we didn't mention that I thought I would mention is a ProCal is also a other test that can be done, procalcitonin, that can be done to help rule out infection as well, that I don't think we discussed initially on the workup. So those are kind of my pearls for the COP. But
Yeah, thank you. In doing some lit review for this, the diagnostic rate, so glad you brought that up because I totally forgotten about it, was 6 to 13 weeks after initial symptoms for COP. And then coincidentally, not planned for this patient, but adrenal insufficiency is also a common misdiagnosis.
yeah, absolutely.
Requiring multiple office visits, a lot of times outpatient, before it's ever picked up on.
Yeah, and I think something to recognize with prednisone is it's often prescribed a lot in the outpatient sector. So just know that really look through and really ask those good questions of have you been on prednisone recently, and recognizing those symptoms, like Lindsay was pointing out so greatly with adrenal insufficiency. And it's something often misdiagnosed, absolutely, because we don't know that patients are on these steroid tapers, or they go get steroid dosing at an outpatient physician that's not in the health system, so you don't see it in the health record. So really getting a good history to see if they were on steroids is definitely something needed.
Yeah, thank you. So we're nearing the end of our time. Brianna, you want to tap through each of those slides so that they can be paused on the video recording? You'll reference one for classification, another for symptoms, which are pretty broad and specific, and then the last one for some of the diagnostic workups. And then we'll get some of the references in for these as well. But lastly, to wrap up for our patient, as we mentioned before, he initially improved a little bit on his O2 requirements and then started to kind of decondition and go downhill. And this was all back in April. So he ended up having multiple COVID tests, which is when your suspicion is high, you had multiple tests. But it's complicated by the fact that that was at a time whenever the institution that we're at was not allowing any visitors. And so the case, and I mean, part of the considerations for what was going on was like, are these symptoms related to loneliness, isolation as well? And is that why he's not improving? And so it's kind of a tragic, heart-wrenching case in that sense. And then palliative care was also ended up being brought on just because the decisions being made of what's the right course of action, what are we going to do? where we're going to go with this. And so I have a twofold question for you, Nikki. One, how do you approach a palliative care case or a palliative care family conversation normally? And then second, how does your approach to that change whenever everybody is remote?
Yeah. So palliative care at our hospital is a fantastic resource. Palliative care in general is a fantastic resource. So something to really focus on with this patient is really describing palliative care in a sense of that palliative care helps with symptoms, and they help with guiding symptom treatment and symptom management, and guiding goals of care conversations and any type of disease progression that this patient should have, especially with all of his comorbidities. He has, heart, esophageal cancer, coronary disease, all this background history. So just knowing that it's not technically something that hospice is not always what we look for in a palliative care consult, that they are good with symptom management, with goals of care, help guiding a safe discharge like we were talking about, and helping bring in family members. So one big thing with palliative care consults is making sure that you introduce the patient to palliative care before you actually put in the consult, because you don't want palliative care to come straight in and start talking, because a lot of people have misnomers about palliative care and thinking that they're going directly to hospice. So making sure that you're describing why you're getting palliative care involved. And in this case, it sounds like he's got multiple comorbidities. They would help in many different avenues with symptoms and overall just goals of care with this patient, and help guiding those conversations with family and patient in the future. So though that would be how I would start things. And I would hope that, family would be there in non-COVID times when you would introduce this, and then you could schedule a time for palliative care to come talk with him and his family, or the patient and the family together. So then you would kind of coordinate that care as a primary team. And then in COVID times, so it's been a little bit different in COVID times, but palliative care has been a wonderful resource during COVID times, because they actually have their own iPads at our institution. So they actually bring in these iPads and help facilitate conversations over iPads and make sure that patients are seen, or families are actually seeing their patients on iPads. So it's actually been a wonderful transition that they've really helped with communication and helped bring, everybody's thoughts together, and make sure that the patient and family are on the same page and updated. So it's been a good transition at our institution, but understandably that it's different at other institutions as well. But palliative care is a wonderful resource to use on not just patients that are acutely crashing and needing goals of care conversations for that direct hospitalization, but also those patients that I think that you think that family would be appreciative of their guidance and their help in the future, and help with all those things that I mentioned before. So.
Yeah. Lindsay, have you had the pleasure of being a part of one of those conversations?
I have not yet. I did do kind of a enrichment week with pain management, which is tied closely. And so got to think about that a lot, and really important part of palliative care, I think.
Yeah, that's a huge portion of it. So it was a pretty special meeting with him, in that he was the grandfather of a whole line of grandchildren that just left him. And so I think there were maybe 12 or 13 different folks on the Zoom call that had kind of been spread out all across the country, like we talked about in the history. Ultimately, the family made the decision after about it'd been about 2.5 weeks of an admission at that point, with a brief improvement and then kind of a decline, to move to hospice so that he could go back home, so that the family could come back and join him. And I don't know what happened after that point. I just know that in that setting, a lot of that decision was predicated on where are we going to be most comfortable for whatever time we have left. And that was almost made easier by the hospital's policy during COVID, because the family wanted to be present, and they could be present at home, but they could not be present at the hospital. And so one of the cases in medicine that just kind of poke at the heart, but then also help you realize that there's a lot in patients' health related to the family that's around them. And there's so much that we could have talked about tonight in regard to the management of disease. And yet this case is almost as much about the management of families as it is about the management of disease. So with that, we've reached the end of our time for this discussion. Lindsay and Nikki, thank you so much. I would love to hear 2 or 3 take-home teaching points that you'd like to highlight for the audience.
My kind of take-home point is I'm still learning to keep a broad differential, and especially when there's chronic disease, remembering that the acute presentations can happen on top of that. And so not just focusing on their past medical history, but looking at it with fresh eyes too is kind of a big takeaway for me.
I really like that. I really like that you said that, keep everything broad, because that's absolutely true. Because in this case, we could have gone directly to one diagnosis, but we kept it broad. And so you have to think about all those things and make sure you rule out those big scary things that can cause, the things that can cause death quickly. So making sure that you rule those things out and keep those things into consideration as well. And then, of course, in this case, interprofessional and working with all of your different team players in order to get the best patient outcome, which it sounds like happened very nicely with this patient, that everything was taken into consideration with all the different interprofessional avenues. So yeah, good case.
Mine would be the safe dispo, that it's largely involved with patient preference, and that you want to go where you're medically safe, but also to a place that provides for the patient's needs. In that regards, some negotiation, working with resources, and navigation amongst all the teams that are involved in the discharge, not merely just the primary provider. Brianna, anything else you would highlight as the scribe for the night?
I think you guys really hit on a lot of it. I think the only things are just like really good teaching points about cryptogenic organizing pneumonia and adrenal insufficiency and how they're often really misdiagnoses. So kind of going back to what Lindsay was saying about those being on your broad differential, and what Nikki was saying with if they've been on steroids, if anyone has given them prednisone, it's definitely possible. So just keeping those in the back of your mind, you could really help a patient by intervening earlier.
Yeah, I'd add one last runaway teaching point, that steroid dose greater than, I'm going to verify my note before I speak. I believe it's greater than 5 milligrams for 3 to 4 weeks is enough to cause a risk of adrenal insufficiency. Somebody please correct me if that is incorrect.
If that is incorrect, we will add a little.
We'll add it to the show notes. So go ahead and tap on the references, and then we will call that a night and wrap up. So thank you all very much for joining us. Thanks for being a part of Decoding DX, and we'll see you next time.